Chief
Nikhila
guest.
join ചെയ്ത പറയുന്നേ.
Can we start? I think the chief guests have joined.
I think, Sarayu, can you please check whether Nikhila
Yes,
Vimal...
she is here. She is here. Let's start. Thank you.
Okay, so we're going to start. Good morning, everyone, and a warm welcome to this enlightening webinar, Think Pink, Think Preventive, Breast Cancer Awareness and Screening, which is part of our October series, which is dedicated to empowering women through early detection and healthy living. This webinar series is being organized by IRIA, Indian Radiological and Imaging Association, AMMA Association, and Swasthi Foundation. This webinar series is a curtain raiser for the Global Preventive Onco Summit that will be held in January 2026. Together, let's spread awareness, encourage screening, and foster hope. Inaugurated on October 1st by renowned actress Ms. Manju Warrior. The last 6 days, we were enriched by the enlightening talks of renowned doctors. And today is the 7th day of this ongoing series. So we begin with our inaugural session, which is graced by distinguished dignitaries who embody leadership in healthcare and public inspiration. First, let's welcome our chief guest, the talented and versatile Ms. Nikhila Vimal. She has played many memorable roles and is a well-known face to all Malayalis and a much-loved actress. She has won the most popular actress award at the Kerala Comedy Flash Movies Award. Nikhila's journey from a child artist to a leading heroine starring in hits across Malayalam, Tamil, and Telugu cinema is truly commendable. We are extremely grateful to Ms. Nikhila Vimal and AMMA Association for joining in this effort to spread awareness of breast cancer. Your voice truly makes a difference in reaching the general public much more than what health professionals can possibly achieve. We are extremely grateful and thankful to Ms. Nikhila Vimal for joining in spite of your busy schedule. And we are extremely happy and grateful to invite you to inaugurate our session. Over to you, ma'am.
Hi, first of all, thank you so much for inviting me to be a part of this webinar. Because എന്നെ സംബന്ധിച്ച് ഇതൊരു ഗ്രേറ്റ് ഇനിഷ്യേറ്റീവ് ആണ്. ഫസ്റ്റ് ഓഫ് ഓൾ അത് ആദ്യം തന്നെ അങ്ങനെ ഒരു ഇനിഷ്യേറ്റീവ് എടുത്ത് നടത്തുന്ന IRIA, സ്വസ്തി ഫൗണ്ടേഷൻ ആൻഡ് അമ്മ അസോസിയേഷന് എൻ്റെ എല്ലാവിധ നല്ല വിശ്വാസം അറിയിക്കുകയാണ്. ബിക്കോസ് ഇത് വളരെ ഇമ്പോർട്ടന്റ് ആയിട്ടുള്ള ഒരു സബ്ജക്റ്റ് ആണ്. നമുക്ക് അങ്ങനെ വെറുതെ ഡിസ്കസ് ചെയ്ത് പോവാവുന്ന ഒരു കാര്യമല്ല. അപ്പൊ അതിനെ ഇങ്ങനെ ഒരു വെബിനാർ സംഘടിപ്പിച്ച ഈ ഒക്ടോബർ 1 മുതൽ 31 വരെ ഒരു പിങ്ക് മന്ത് ആയിട്ട് ആചരിച്ച് ഇത് ഈ പറയുന്നത് പോലെ സ്ത്രീകൾക്ക് ഇത്രയും ഇമ്പോർട്ടൻസ് കൊടുക്കുന്ന ഒരു കാര്യമായിട്ട് ഇതിനെ ഡിസ്കസ് ചെയ്യുന്നത് ഒരു വലിയ കാര്യമാണ്. അത് എൻ്റെ വീട്ടിലും പറയുകയാണെങ്കിൽ എൻ്റെ അമ്മയ്ക്ക് എൻ്റെ അമ്മ ഒരു ക്യാൻസർ സർവൈവർ ആണ്. അപ്പൊ അമ്മയെ സംബന്ധിച്ച് അമ്മയെ ഞങ്ങൾ എല്ലാ 6 മാസം കൂടുമ്പോഴും ചെക്കപ്പിന് കൊണ്ടുപോകുമ്പോൾ നമുക്കറിയാം അതിന്റെ ഒരു ബുദ്ധിമുട്ട് എന്ന് പറയുന്നത്. അപ്പൊ നമുക്ക് അതിന്റെ ബുദ്ധിമുട്ട് അറിയാവുന്നത് കൊണ്ട് തന്നെ എന്താ പറയാ, ഓരോ പ്രാവശ്യം പോകുമ്പോഴും അതിൽ നമ്മൾ അനുഭവിക്കുന്ന ടെൻഷനും അതിലനുഭവിക്കുന്ന കാര്യങ്ങളൊക്കെ അറിയുമ്പോൾ നമുക്കറിയാമല്ലോ. ഞാൻ ഓരോ തവണ ഹോസ്പിറ്റലിൽ പോകുമ്പോഴും അവിടെ ഒരുപാട് ആൾക്കാരെ നമ്മളിങ്ങനെ സർവൈവേഴ്സ് ആയിട്ടും പേഷ്യൻസ് ആയിട്ടും ഒക്കെ കാണുമ്പോൾ നമുക്ക് ഏറ്റവും പ്രിയപ്പെട്ട ആൾക്കാർക്കൊന്നും ഇത് വരരുതേ എന്ന് നമ്മളെപ്പോഴും ആഗ്രഹിക്കും. അപ്പം അതിനുള്ളൊരു അവയർനെസ്സും കൂടിയായിട്ട് നമുക്കിത് കൺസിഡർ ചെയ്യാം. കാരണം എല്ലാ സ്ത്രീകളും ഒരു 40 വയസ്സാവുമ്പോഴത്തേക്കെങ്കിലും ഫസ്റ്റ് മാമോഗ്രാം ചെയ്യണം എന്നുള്ളതാണ് എനിക്കറിയുന്ന ഒരു കാര്യം. അപ്പൊ എനിക്കറിയാവുന്ന കാര്യങ്ങൾ വളരെ ലിമിറ്റഡ് ആണ്. അപ്പൊ നമുക്ക് മാമോഗ്രാമിന് ചെയ്യണം എന്ന് പറയുമ്പോൾ നമ്മൾ ചെയ്യാന്നുള്ളതിൽ കവിഞ്ഞിട്ട് നമുക്ക് ആർക്കും അതിനെപ്പറ്റി ഒരു വലിയ ഡീറ്റെയിൽഡ് ആയിട്ടുള്ള കാര്യങ്ങൾ സംസാരിക്കാൻ അറിയില്ല. അല്ലെങ്കിൽ നമുക്കത് നമ്മുടെ വീട്ടിലാർക്കെങ്കിലും വരുമ്പോൾ മാത്രം നമ്മൾ ഇതിനെപ്പറ്റി കോൺഷ്യസ് ആവുന്നു എന്നുള്ളതിൽ കവിഞ്ഞിട്ട് നമ്മളിങ്ങനെ ഒരു വെബിനാർ സംഘടിപ്പിക്കുകയും അതിൽ ഇത്രയും ആൾക്കാർ ഇതിനെപ്പറ്റി ഡിസ്കസ് ചെയ്യുകയും ഡോക്ടേഴ്സിന്റെ പ്രസൻസിൽ അവർ പറയുന്ന കാര്യങ്ങൾ അറിയുകയൊക്കെ ചെയ്യുന്നത് ഒരു വലിയ ഇനിഷ്യേറ്റീവാണ്. അപ്പോ അതിന്റെ ഭാഗമാവാൻ സാധിച്ചത് വലിയ സന്തോഷമാണ്.
Thank you so much, Nikhila ma'am, for that thoughtful message. So thank you so much for joining us today. And if time permits, please do stay through the end of the webinar.
Okay.
So next, I would like to welcome Dr. K.K. Manojan, Vice Chairman of GG Hospital, and Sri Gokulam Medical College and Research Foundation. He's also a trustee of Swasthi Foundation. He's a distinguished physician holding MBBS, MD, and FRCP qualifications, who leads with a focus on quality healthcare delivery and has been awarded at events like 24th Annual Conference of Society for Emergency Medicine. Dr. Manojan is a very vibrant and dynamic leader. Dr. Manojan's administrative expertise in steering multi-speciality hospitals towards excellence inspires us all. And we look forward to his insights on integrating prevention into our oncology summits. He has also been involved in various philanthropic and social activities and has always been an active participant in all the awareness campaigns which is conducted by Swasthi Foundation. We are proud and privileged to welcome you to this webinar series and deliver the inaugural message. Over to you, sir.
Thank you, Devika, Devin, and most respected dignitaries, especially the chief guest of the day, Nikhila Vimal, Dr. Anu Sara, Dr. Sony, and other members who have joined today in this webinar. I'm more than happy to be a part of this excellent awareness, particularly cancer awareness campaign organized by Swasthi Foundation. As far as I'm concerned, I've been a member in Swasthi for the last 10 to 12 years. Ever since they started, I am also part of it. I know how much effort they are putting, particularly the members, those who are in the forefront. I mean, without mentioning his name, you know, Mr. A.B. George, who is the linchpin of Swasthi Foundation, who's in the forefront in, you know, particularly cancer campaign and, you know, early detection. These are something every healthcare worker is certainly very much interested in, and I'm glad that I am also part of this initiative. As far as Gokulam Medical College and GG Hospital is concerned, we've been a part of this initiative for the last 1 decade, and we have excellent team of you know, members who are giving their best for the last 10 years, and it is a selfless contribution, rather I can put it. So നമുക്കെല്ലാം ഒരു നല്ലൊരു പ്ലാറ്റ്ഫോമാണ് സ്വസ്തി ഫൗണ്ടേഷൻ ഉണ്ടാക്കി തന്നിരിക്കുന്നത്. തീർച്ചയായിട്ടും as far as cancer is concerned, we all know the fact that it is a major concern nowadays, particularly being in Kerala. If I can share my experience, as far as Gokulam Medical College is concerned, way back in 2005, when we started our medical college, we did not have a cancer department in our hospital. Later, then we decided to start a cancer department when we started noticing the number of patients coming to other specialties. Like, you know, they were diagnosed to have malignant, that is carcinoma of breast, carcinoma of, you know, colon, and so on. So we thought, okay, then it is wise to start a cancer department, particularly medical oncology and surgical oncology, because you know the fact that starting radiotherapy is a costly affair. So initially we thought of starting that. But initially we had only little patients coming in. Few patients were there early in 2012, 13, 14 and all. But of late, I can see the number of patients has increased so much that I think it is a major concern. When I inquired about cancer in other states, comparatively it is less. So certainly it's a warning sign for Keralites. We have to do something. So that is what I realized, that, you know, being in a medical college, it is our responsibility, not just a charity. It is a responsibility of a healthcare worker to come forward and do whatever best they can do it to save the society from this, you know, fearful cancer. But the fact of the matter is, nowadays, you have so many solutions are there. If it is detected early, more than that, like, you know, even if it is detected, if you don't take appropriate treatment from the known centers, you cannot just go and take treatment from anywhere which is not recognized for cancer treatment. That is very important. Nowadays, that is also becoming a matter of concern, because everyone started treating cancer now. That should not be happening, because that is what I think, being a body like this, where you have many doctors, particularly from RCC and so many other well-known cancer centers, being a part of this organization, I think it is our responsibility to share important, you know, message to the society. Through this platform, I'm sure we will be able to convey many more messages through which we can save many lives. വളരെ സന്തോഷമുണ്ട്. എനിക്ക് ഒത്തിരി സന്തോഷത്തോടു കൂടെ എബിച്ചായനോടും അതുപോലെ തന്നെ ബാക്കിയുള്ള എല്ലാ മെമ്പേഴ്സിനോടും പറയാനുള്ളത്, ഗോകുലത്തിന്റെ ഭാഗത്തു നിന്നും GG ഹോസ്പിറ്റലിന്റെ ഭാഗത്തു നിന്നും ഞങ്ങളാൽ കഴിയുന്ന എല്ലാ സഹായം നിങ്ങൾക്ക് എക്സ്റ്റെൻഡ് ചെയ്യും. അതോടൊപ്പം തന്നെ ഈ ഇനീഷ്യേറ്റീവിന് എല്ലാവിധ ആശംസകളും നേരുകയാണ്. നന്ദി, നമസ്കാരം.
Thank you so much, sir, for those inspiring words. Let's carry that momentum into our expert talk on the importance of mammography and other screening tools, and when should a mammogram be planned. We are privileged to have with us two leading radiologists to guide us, Dr. Easo and Dr. Sony KM. First talk will be by Dr. Easo, Associate Professor in charge of Women's Imaging at MOSC Medical College, Kolenchery, Ernakulam, and a General Council member of the Breast Imaging Society of India. Dr. Anu's contributions to radiology education and research make her an ideal voice for demystifying screening tools. We are very happy to invite you, madam, for this talk. And I would encourage you to have it in Malayalam, because we also have many guests in English, because we have many guests from outside Kerala as well. Over to you, madam.
Can you hear me?
Yes, ma'am.
Is my screen visible?
Yes, it is, ma'am.
So very good evening to all of you. And I'm going to present about the role of mammogram and other screening tools in breast cancer. Hi, I'm Dr. Easo. I'm Associate Professor in charge of Women's Imaging, MOSC Medical College, Kolenchery. So why we should talk about mammogram and about screening? Because breast cancer, it is the most common cancer among women. And early detection will definitely improve the survival. And screening will save lives. And it's a life-saving habit. So in India, nearly 60% of breast cancer cases are diagnosed in stage 3 or 4 of the disease. That is, it is at an advanced stage. And that shows that screening is not done regularly by many women. So when it comes to a 5-year survival rate of breast cancer, it is seen that for a stage 1, it is around 95%. However, when it comes to stage 4, it drops down to 21% only. That shows the importance of detecting the cancer early. So survival rate is poor in India compared to Western countries due to early age at onset and late stage of the disease at presentation, delayed initiation of definitive management, and inadequate treatment. So what is screening? You're checking for cancer even before you have any symptoms. That is, even before you're able to even feel the cancer by yourself. So what is your goal? You want to catch it early, treat it early, and save lives. So these are the assessment categories which a radiologist use to categorize all the screening reports. So in mammogram or in ultrasound or MRI, we use BIRATS categories. And this category 4 and 5, these are the suspicious categories. And when a person comes into these categories, we advise further evaluation like for a biopsy. So is mammogram useful? So there are many studies which shows that doing screening mammogram will definitely reduce the breast cancer mortality. And when we should get mammogram done, the next speaker will talk in detail about that. It's after 40 years. And if the person is high risk, it can be started at around 30 years. So what is a high risk? If you have a relative with breast cancer, if you have a genetic problem, then the screening starts early. So the gold standard for screening is mammogram. And in mammogram, what we do is we use X-rays, but the mammogram machine is different. We use different type of X-rays for a mammogram machine. And what we do here is the breast is positioned inside the machine, and the X-rays are passed through the breast to obtain a image which shows early changes of cancer. Like there can be calcium deposits, or there can be some small changes in the breast, which are all predictive of cancer. So it is a gold standard. We use low dose X-ray. That is some concern for some people. People generally ask, is the radiation too much? No, it is a very low dose X-ray to the breast, and it can detect small calcifications. It is highly accurate, and even small white specks can be a cancer. And this should be evaluated by an expert radiologist. So this was one of my patients, and she came for a checkup, and a mammogram was done, and the arrow points towards a small shadow, which was later evaluated and seen that it was a cancer. The patient did not have any complaints, so she just came for screening, and this very tiny 5 millimeter lesion was picked up, and she had it treated. So this shows the importance of doing a mammogram for early detection. So this is the ultrasound images of the same patient, where you can see that it's a very tiny, not even a centimeter. The lesion was detected and it was biopsied, so the patient could take early treatment. Another case, a 60-year-old lady with, in this, as you can see, there are some calcifications. Some calcifications can be signs of cancer. So here again, biopsy showed that it was an invasive cancer, and she took the treatment early. So what are the other screening tools? The other screening tools are ultrasound. The ultrasound can be used for dense breasts, and it is generally radiation free. And MRI is used for very high risk women. That is, already I told you that if a woman has genetic problems, or if like there are certain oncogenes, or if the relative has a cancer, then then MRI is used for screening. Also, other screening can be done with self-breast examination, and each modality will complement mammogram, but it won't replace mammogram. Mammogram is the gold standard. This is an MRI image of a breast cancer patient, and the red arrow points towards a cancer, where it is seen to be a very bright lesion. And you can see some graphs and all that. And these graphs are known as kinetic curves. And this is used to evaluate the how the cancer takes up the contrast which is injected to the patient. And so all this helps us to know the extent of the cancer. And MRI is a very sensitive tool for detection of cancer. And there are certain myths and facts about mammogram. Is it painful? There will be mild discomfort, but it's not very painful. And some people believe that if there is no family history, then there is no risk for breast cancer. No, if there is, most of the patients don't have any family history. Another myth is only older women get cancer. No, younger too will get. And some believe that if they don't have any symptoms, they don't have cancer. No, it is often silent. So what happens during a mammogram? During a mammogram, it is a simple outpatient test where it can be done within 20 to 30 minutes, and there'll be gentle compression of the breast for clearer images. It is interpreted by a radiologist, and not all abnormal results are cancer. It will need more tests to say whether it is cancer or not. And the impact of early detection, as I told you before, if it's a stage 1 disease, survival is more than 95% compared to the lower survival in the advanced stages of breast cancer. And early detection means smaller surgery, lesser complications, lower cost. So one timely mammogram can change a person's life. So let's schedule your mammogram, encourage your friends and family, Stay breast aware and healthy. Join awareness drives. Share the knowledge. And as a radiologist, I know that there are so many cases of where I've seen that just that mammogram, which helped the patient to for early detection of cancer and saved their lives. So every year, women survive because of one tiny mammogram. So let's make screening a culture and not an afterthought. Thank you.
Thank you, madam, for the informative and insightful talk. If you have any questions, please raise them in the chat box. Dr. Rujo, will you like to add anything? I think we'll move on to the next talk. So next we have Dr. Sony KM, Head of the Department of Radiology at Valluvanad Hospital, Ottapalam. She is a renowned professional with MBBS and MD in radiology with over 15 years of experience in advanced diagnostics facilities. Her practical insights on mammogram timing will empower attendees to take proactive steps. Over to you, madam, for this vital discussion.
Thank you. Is the PowerPoint visible?
Yes, ma'am.
Good evening, everyone. It's indeed a pleasure to be among such inspiring leaders, teachers, and respected colleagues. And my sincere respects to the chief guests of the day, the eminent leaders of IRIA. And today, what I'm going to talk about is something which truly matters. It is when and how often we should get our mammograms done. I'll move to the topic. To begin with, a big congrats to Kerala IRA under the eminent leadership of Dr. Rijo Matthew sir and the Association of Malayalam Movie Artists and the Swasthi Foundation for such an inspiring move. Think pink, think preventive about breast cancer awareness and screening, which will be empowering for most of the women in the means of both creating awareness and prevention. From all these topics, we have already understood that mammography is a best screening tool for breast cancer detection. And mammography are of two types, usually, which are the screening mammogram, the first type. Screening mammogram, we have already heard, it is done in patients who are usually not with any symptoms or any signs which are pointing towards a cancer. These we do in patients for an early detection of cancer because time is gold in case of cancer because it can lead on to better treatment modalities and better survival rates. And the next one is a diagnostic mammogram, which is done in patients who present with these kind of symptoms like a breast lump or some discharge from the nipple, especially a blood-stained discharge, or other signs like skin changes or some patients with pains. All these signs which may be pointing towards malignancy, and diagnostic mammogram is performed in such patients to detect whether there is any malignancy. So my topic is when to go for a mammogram. First thing is about the breast screening recommendation. The breast screening recommendation by BISI, the Breast Imaging Society India, is to begin at an age of 40 years for women at an average risk. So, what is an average risk or otherwise a low risk? These are patients. About the high risk patients, we are going to discuss. These are the usual patients or the general population who are usually at a low risk for breast cancer. In them, we advise a screening mammography at 40 years of age, and they have to undergo annual mammography from the 40 years of age to 70 years annually to be done. And beyond the 70 years of age, it is up to the decision of the examination of the patient with regard to patient's general condition, life expectancy, etc. We have to decide on how frequently the patient should undergo a screening. And when we were talking about the average risk, there is another group whom we call the high risk group or higher than the average risk group. They are people who have a lifetime risk of breast cancer more than 20%, which is a significant amount. So these are patients with a family history of first degree relative with breast cancer or some genetic mutations which are known to predispose to breast cancer, or a first degree relative with the genetic mutation and the patient themselves does not have a genetic study done as of now. And next is a group of patients who might have received a radiation therapy to the chest during their younger age groups, like from 10 to 30 years of age. So these are the high risk groups. So these high risk groups should undergo a bit more earlier screening. So they should undergo a screening annual mammography. And at a younger age group, people should also have an adjunct MR mammogram also. And when to start this? This should be started from an age of 30 years of that patient or 10 years before the diagnosis of cancer in the first degree relative, whichever is later. So from there, they should undergo a screening annual mammography yearly and along with an adjunct MR mammogram depending on the situation. So next comes the diagnostic mammography. So when a patient comes with a lump or any discharge or something which may be pointing towards a breast malignancy, so who all will go to X-ray mammogram and who all will go to other investigations? If the patient is at an age of above 40 years, definitely no doubt patient goes to mammography because that is an age group even when we start this annual screening mammography. When and those symptomatic patients, the recommendation is women more than 30 years should go for mammogram. But there is a clause there. In the 30 to 39 years age group, the patient should undergo thorough clinical evaluation to look for any dense breasts. Dense breast is a concern always because dense breast cannot be well easily evaluated by X-ray mammogram. So they should be thoroughly examined clinically for dense breast and depending on the clinical presentation of the lesion. If it is totally benign appearance or it is pointing towards or not fully benign appearance. In such cases, patient may go for ultrasound or MR mammogram, depending on the clinical decision. Next is the other group, who are patients less than 30 years of age, or those patients who are not who cannot receive radiation, so they are pregnancy and also in lactation early periods. USG is recommended as the first screening. So, and in them, if the USG shows a suspicious lesion or it is dubious, again they go for mammogram, either X-ray or MR mammogram, depending on the situation. That's about the screening mammography. Screening, whether it is screening mammography or digital mammography, about the frequency. Now, regarding when you should plan for or schedule your mammogram. the timing of mammogram. One thing of concern for many ladies is that whether there will be pain during the procedure of mammography, because during the this procedure, mammography, breast will be placed in the mammogram machine between the imaging plate, and there will be a compression paddle which lightly compresses the breast tissue. This is just to even out the breast, to give a clearer image and just to give a clear idea of whatever is happening, as ma'am told, even for a lesion which is less than 0.5 centimeter, which is much earlier, depending when we consider the clinical presentation, which will take at least to like 1 to 2 centimeter size of a lesion, which takes some time. So many are concerned about whether there will be pain during this compression. To tide over that concern, ideally, we should plan to schedule our mammography at a 1 to 2 weeks period after your periods. That is, aim at a date which is 1 week after your menstrual bleeding. Avoid those tender times of breast, like 1 week before the next period or the period of blood flow. So, in that, it is that period where the breast can be tender and might cause some discomfort for the discomfort for the patient. And the advantages of this kind of timing for or scheduling for the mammography is that will reduce discomfort, and it will give more clearer images also, since the breast is having minimal amount of inflammation during those periods. So this is about the timing or when to schedule the mammogram. And so what we'll do on the day, or what preparation you need for the mammogram, there is no much of a preparation. It is better to avoid talcum powder, deodorant, lotions, or perfumes on the breast or underarms on the day of examination, because that can cause some kind of artifacts, might cause, and this might be hindering for the imaging purpose. And you go with all the previous reports, whichever you have, that's good to go. That is, these things are that is all about the preparation for mammography, scheduling mammogram, and how to time your mammogram. These things are said easy, I know, but it is a long road to help patient understand the importance of mammography, and to get an adequate screening, so that the breast cancers are detected early. But every small step goes a long way, like the continued spread of awareness, the compassion, and teamwork, which can go a great way. And we'll expect in future there comes a day where the breast cancers are detected early and lives are saved. Think pink, think preventive. Thank you.
Thank you so much, madam, for that informative talk. So if you have any questions, please do raise them in the chat box. We have many expert doctors with us, like Dr. Rijo, Dr. Ansar, and Dr. Mohan Shenoy. Would you like to add anything?
Uh, uh, Thank you, Devika, wonderfully anchoring this session. And two of our good speakers, Dr. Anu Sara and Dr. Sony, has given some wonderful presentations. Is Dr. Ansar here? Or,
Yes, I'm here.
Yeah. Dr. Ansar, there is a lot of confusion on the guidelines sometimes. India has got a specific guideline. Breast Imaging Society of India has come out with some guidelines. But what are the current guidelines that, as a national, do we have any national guidelines for as of now?
We don't have a national guideline for screening for breast cancer, but what we currently follow is guidelines adopted by Western countries, which we use opportunistically for screening the patients who come across in the clinics. There is no population-wide screening programs presently in India.
Right. So that is why when I've seen gynecologists advising maybe 40 years, once in 2 years or 3 years. Yesterday also we heard such an advice. So we see a little bit of there is no uniform advice coming in. So after 40 years, is it required to do mammogram every year, even if it is a low risk or an average risk?
It depends upon if the patient is at a higher risk or a normal risk. What we currently practice is patients who are at a higher risk of developing breast cancer. Example, the patient have a positive family history, a first degree relative, or more than two second degree relatives having breast cancer, or already the patient is known that the relative is a BRCA gene mutation present. In such situations, we are clear that 10 years before the earliest age of onset of cancer in that family, we have to start screening, usually with an X-ray mammogram, and annually we have to do up to 70 years. And if the patient herself is a BRCA mutant positive and she has breast cancer in one of the breasts, then she has to undergo screening in every 6 months, alternating with the X-ray mammogram and MR mammogram. For this, guidelines are very clear. But for a normal population risk patients, there is no clear-cut guidelines. So doctors are using convenient guidelines for themselves. Some people will say start at 40, take one mammogram, then do it after 3 years. But on a scientific point of view, there is no justification or no rationale for doing screening in once in 3 years or 6 years, because the cancers can come within that period, and we can miss cancers in between these 3 years. So if we want to do a screening mammogram, it has to be done at least annually. Then only the purpose of screening will serve.
Right. Especially in the Kerala circumstances where we are seeing an increasing number of cancer breast incidents, which is almost equivalent to that of in the Western scenario.
Yes,
Right.
that's right.
So exactly, this is the point I wanted to highlight, because even though the general public approaches many different doctors in different specialties, they get advices in a different way. The surgical oncologist, medical oncologist, or a breast imaging specialist may tell you to follow these guidelines after 40 years, even if it is a low risk group, annually, because the incidence is now coming down into the 40 to 55 age group. But I've seen many other specialists who may be advising, especially the gynecologists, to whom most of the time the ladies may be approaching first, advising them maybe once in 2 years is okay, or once in 3 years is okay. But that's not the kind of right advice should be followed in the Kerala society, especially with the higher incidence of breast cancer rising up in our population. So that's the point I just wanted to highlight. With the different kind of advisors now coming in, it is time for the medical community to come into terms with some kind of a uniform advice. Like high risk group, definitely the guidelines are very, very correct, very clear cut guidelines are there. But for the low risk group, there is an ambiguity in the guidelines, ambiguity in the advices provided by different medical specialties. So it's time for the medical specialty also to come into some kind of a uniformity in giving advice to the general public. And sir, any other point to be
Yeah,
added?
that you are rightly said, sir. If we are planning to do a screening mammogram for an individual, then it has to be done at least once in a year, starting at the age of 40 years and up to 70 years. Then only that will come under the definition of screening. All other screening methods are not sufficient to pick up early lesions. If you do it once in 2 years, if you take the doubling time, tumor doubling time, even in a less aggressive tumor, a tumor can become double in size in 2 years. So if we start screening in January of 2025, and if we wait for 2027 January, she would have developed cancer in this 2 years' time. So we have to do, if we are doing a screening mammogram, at least once in a year we have to do.
Question to
Doctor,
Dr. Yeah,
yeah,
please, sir. Go ahead. Go ahead.
question to, there are two questions to Dr. Ansar. First one is that if you have a person patient coming to you with BRC positive, mutation positive, would you advise them to undergo surgery immediately or not? That is the first question. The second is like, would you advise a wealthy patient to undergo a mammo or MRI? Which is the ideal one to undergo?
Okay, sir. So to the first question, if the patient herself is a BRCA gene mutation positive, and if the patient has no disease, she has tested because of her relative was diagnosed to have cancer and they did testing, and now she also took testing. Now she found to be having BRCA positive. This is first scenario. In that situation, we will ask the patient at what age the relative got breast cancer. So there is something called anticipation. 10 years early in the next generation, the malignancy will come. So if the patient is approaches the same age, if the mother got cancer at 40 years, the patient is also 40 years, and we will do the investigations to find out if there is a disease at that time or not. That means we'll do mammogram and MR mammogram. If there is no disease and she is BRCA mutation positive, then we will give the option of prophylactic mastectomy with the reconstruction and risk reduction salpingo-oophorectomy. Whether you can do both, or you can do MR mammogram and X-ray mammogram alternating every 6 months, and ultrasound abdomen and CA 125. This is what we advise. And in practice, what we have observed that most of the patients, in fact, none of the patients in our setting has opted for a prophylactic mastectomy and reconstruction. And the patients who are on follow-up with the X-ray and MR mammogram is on follow-up. Nothing has happened. Even younger patients are there. We started screening at the age of 25 and they have crossed to 32. They have not developed any breast cancer now. So because the chance of developing breast cancer by the age of 70 in a BRCA 1 and 2 positive ranges from 40 to 60%. All of them will not develop breast cancer because this mutation does not have 100% penetrance. Even though they have a mutation, they will not develop breast cancer in their lifetime. The chance is only up to 60% by the age of 70. So they very well can opt for close follow-up mammograms. And second question, I forgot, sir. What was second question?
You have
It's
a
an affordable patient.
No, for all screening purposes, if the patient is at a population risk and the breast density is less, that means the patient is above the age of 40 and the breast density is less, X-ray mammogram and an ultrasound will be sufficient. If the breast is dense and X-ray mammogram does not show clear-cut lesions, it may obscure lesions, then we will advise for MR mammogram. And if the patient is non-BRCA mutant positive or check mutation positive, then definitely MR and X-ray has to be taken alternately in every 6 months. So if the person has enough money to do an MR mammogram, it will not justify doing MR mammogram because MR mammogram picks up lot of lesions because it's too sensitive. So it will pick up more and more lesions, and we have to run behind those lesions. So X-ray mammogram is the ideal screening imaging. And if there is an indication for an MR mammogram, such as a dense breast or less than 40 years of age or a BRCA mutation positive, BRCA carriers, in those patients, MR mammogram is advised.
Thank
I
you.
have a question to Dr. Sony and Dr. Anu. We have seen many patients who had X-ray mammography complaining of pain. They had pain during this thing. So how will you counsel those patients when? Because many times I've seen patients trying to avoid the X-ray mammography the second time and trying to adjust it with ultrasound mammography and try to see. So how will you advise or how will you counsel such patients?
One thing what we can do is tell them to do the mammogram as Dr. Sony told, that in the first few days after the menstruation. If it's towards the last part of the cycle, then again the breast will be tender. Then reassurance is a big thing. Then probably that can do wonders, I believe.
So avoiding the menstrual period as well as 1 week before the period to avoid the tenderness in the breast. So predominantly in the midweek is better. That's a suggestion. And a little bit of counseling and reassurance from the radiologist can help them. So advantage. So even I've seen many patients insisting on I don't want to go for it. Can you manage with ultrasound alone? So what will you advise for such patients? Because we know that microcalcifications can be picked up with X-ray mammography alone, and ultrasound may not be in a position to pick up that microcalcification. So how will you recommend to very adamant patients? And another question is, even in very dense breast, is mammography 100% sensitive and specific?
Yes, so definitely in dense breast, mammogram is not sensitive. What we have to do is MRI or ultrasound. And in patients who insist on ultrasound, definitely they'll have to be counseled that only lesions which are calcified lesions need not be detected. And early cancers usually are small pleomorphic calcifications. And if they insist further, then probably I would do ultrasound for them if they know the risks and benefits of doing ultrasound.
Yeah.
Yes.
Yeah, understood. But these are the practical scenarios that we come
Yes,
across
yes.
and many patients have got a lot of apprehensions on the pain during, or it's actually may not be very painful, but if it is done very properly by in the proper method, and after proper reassurance, I think mammography is quite a easy examination. Any more questions from the audience, Ansar or any other?
So anybody want to ask questions or put a message? Want any clarifications?
One point which I want to make here is if we screen with MRI, as Dr. Ansar said, it's very sensitive and it will pick up very small findings which may not be significant. So, and MR guided biopsies are not widely available also. So that can lead to a lot of confusions if we screen with MRI. So I want to ask Dr. Ansar, if you are regularly screening, how do you deal with such cases, which is only seen on MRI but not on ultrasound?
So that
Mammogram.
we come across such cases. So we have a very good intervention radiology team. So every mammogram, MR mammogram, which is taken, is discussed, and the same patient is being screened with ultrasound. Now our radiologists are so well versed; they are able to find out even the tiniest lesions in the from the MRI in the ultrasound. So even though we don't have an MR guided biopsy platform, but practically we are solving that issue by comparing the MR mammogram and with the ultrasound. Nearly 90% of the time we are able to pick up the lesions. If we are not able to pick up those lesions, we will keep the patient on a follow-up, close follow-up. We'll ask for a repeat mammogram, an ultrasound after 3 months if the suspicion is very high, and a mammogram at 6 months. If it is a small architectural distortion, it will progress if it is a real lesion. If it is a non-mass enhancement in the MR mammogram, if it is real lesion, it will become a mass. in the next mammogram. So if we are not able to do biopsy, we'll keep the patient under close follow-up. But nearly, as I said, 90% of the time, our radiologist is able to identify the finding in the MR through ultrasound. So we will put a guide wire into the lesion and we will remove those non-palpable lesions and send for frozen section. And if there is malignancy, we do the sentinel node in the same sitting itself. That's what we do because radiologist and surgical oncologist, everybody is closely working together. In fact, the OPD of our international radiologist is the same in oncology OPD. So that is how we manage such difficult situations.
So that has rightly highlighted the importance of multidisciplinary teams in the management. Devika, I think we are through with the questions. You can wind up the session.
Okay, so we'll be moving on to the vote of thanks. So first, I'd like to thank all you doctors for adding those wonderful insights to the questions. So as we conclude this impactful webinar, let's remember to think pink and think preventive. Early detection through mammography and screening can change lives. A huge thank you to our chief guest, Nikhila Vimal, for her star power and advocacy, Dr. KK Manojan for his visionary leadership, Dr. Anu and Dr. Sony for their expert guidance, and a huge thanks to IRIA, AMMA Association and Swasthi Foundation for making this event a reality. Last but not the least, a huge thanks to all of the attendees for joining this curtain raiser for the Global Preventive Onco Summit 2026. Join us daily for the webinars, which will be starting at 7 p.m. and will be culminating with the Pink Walkathon on October 31st. Together, let's build hope. Thank you so much and have a good night.
Thank you, Devika.